done in our lab, ANI. And as Dr. Griffiths mentioned, we have a nice lab with a nice view, so one wouldn't get bored or feel lonely while working for long hours. We have 12 stations in our lab, equipped with microscopes, with high-speed drill and 3D projection, also with wide screens and head holder, also with Aboud model. We have an additional space also for using the whole body, so other kind of surgical training other than neurosurgical training can be done in our lab. Now, going back to the subject, in the light of this tremendous advances in surgical techniques and surgical modalities, the strategy of see one, do one, and teach one is no longer valid now. We need other models that can accommodate our needs. We need to reach the level of see one, simulate many, do one competently, and teach as many and as much as you can. Now, a wide range of training modalities available. We will go through all of them one by one. The web-based education, it's not of that impact on teaching surgical skills rather than stimulating and teaching surgical knowledge, so it's out of our question. Virtual reality and computer models is of great importance in teaching surgical skills and techniques. It can simulate any surgical conditions, but as you can see, it's some kind of computer game. It doesn't teach the mechanical skills. So some of the provider has paid attention to that, and they started to incorporate models that can teach mechanical skills connected to the computer, like this skull-based or skull model. So you can drill and practice this mechanical skill while you are looking at your computer and see where you are drilling. So they are developing this, but it's still not the thing that we want for surgical training. Other modalities are high fidelity human patient simulators, which is life-size computer controlled mannequin that include a mechanical lung and simulated gas exchange mechanisms with heart rate, exchanged heart rate. Some of them can blink and can even scream when you touch a painful area. But it's to teach how to handle the patient and some clinical situations, not of that much impact in teaching surgical skills. The one on the right, that soldier, it can teach some surgical skills, clamping the bleeding arteries and using tourniquet, but it didn't reach the level that we want. Live animals, as you might know, is being used for surgical training, but it's decreasing now because it provides, watch here, it provides the life-like surgical field, bleeding, pulsation. Here is dissecting the carotid in an anesthetized pig, but it doesn't represent the same human anatomy. It's something like playing soccer in a basketball field. Now, human cadavers are the perfect model to teach surgical skills. Of course, I'm talking about traditionally prepared human cadavers. But watch here. Here, opening the Sylvian fissure in a human brain injected with no bleeding, no pulsation, no CSF here in the brain. So what we need is more. This is not enough. We need a model that can provide us with the same anatomy along with the lifelike conditions. Not many of us can find such a nice father that can allow his son to practice surgery on him. So we made cadavers live for surgical training. Of course, we didn't mean this or this. What we meant is to add some features of live surgery to cadaver models by filling the vessels with artificial blood under pressure and apply pulsation to the arteries. The preparation started with evacuating and draining the post-mortem blood from the specimen and clean the vessel completely. Then cannulate the vessels. We can use the neck, the groin, any inlet to the vessel in the body. Then connect the vessels to artificial blood reservoir, and then we further connect the arterial reservoir to a machine that provides the pulsating pressure. We can of course use the whole body, or we can use just a part, the arm, the leg, and the head. Here is the setting of the OR operating station. You can see through simulation, ventilator, monitors, IV bags, and the whole setting of a real OR. Now I'm going to show you some examples, and this is the goal of simulating the whole surgical procedure where everybody can involve, not only the surgeon, the nurses, the paramedics, anesthesiologists. So here we are simulating a patient who just came to the ER with a knife in the chest and it's bleeding, so the whole team come, put IV, put central lines, and surgeons start working and looking for the injury site, and here it is, step onto the left ventricle using the Foley catheter maneuver, and watch here, while they are suturing, they puncture the balloon. This is a perfect model to practice how complications and how things might go wrong and how to fix the complications and do the surgery the right way. Exercise in neurosurgery, practicing how to dissect and clip aneurysm. We create artificial aneurysms on the vessels in the brain and allow trainees to practice how to clip them. Not only that, also to practice how to deal with intraoperative rupture of an aneurysm, to be safe and confident when such thing happens during a surgery on a live patient. There is no other training model where we can teach or practice such technique. Also, when we apply this model to animal cadavers, you might know some of veterinary schools still use live animals to teach their doctors how to perform surgery. So we can use the same technique with ethically obtained animal cadaver, and here showing a biopsy from the liver in a dog cadaver. So you can see the bleeding from the liver and attempt to coagulation, and it coagulates and is done as if it was a live patient. And here is open surgery. You notice the pulsation in the viscera. We patented our work. The model is recognized and cited in the medical modeling and simulation database of the American College of Surgeons. We published our work in the Journal of Neurosurgery and the Journal of Alternative to Animal Models. This model is the only existing model that combines the real anatomy with the lifelike condition at the same time. Comparing it with live animals or cadavers, you can see it provides all the requirement for real life-like surgical training, and a small questionnaire of a pool of 22 surgeons. Most of them, they agreed that this was a true simulation of the conditions of live surgery, and it offered benefits that are not existed in other training models, and it's a valuable addition to current models. Now, all cadavers used were ethically donated and remain returned to the source. One may say that how can we get enough cadavers? So you might know that human tissue donation programs are all over the country. Most of the medical schools have its own donation programs. And for me, actually, providing a human cadaver is easier than having a live animal for testing. Now, it's a cost effective. It will not cost more than $2,500 for each course. Finally, we believe that this model is the perfect alternative to animal use for surgical training, and an essential tool in trauma, vascular, and military surgical training. And in the future, it will be the first surgical case for all residents in all surgical specialties. And finally, I would like to